Faith Forward Media. This is Healthcare Musings. I'm your host, Dr. Hashem Hasabala. Welcome to Healthcare Musings, everybody. Happy to have you with me. So, continuing on in the theme of saving primary care, not infrequently do I have a patient that comes in to the ICU who's been hospitalized multiple times over the past 6 months. Let's say for the sake of argument, it's a person in their 50s. They have end-stage kidney failure. They're on dialysis. They have severe heart failure. And they come into the hospital from the dialysis center because the blood pressure is super low on dialysis. So they get admitted to the hospital, and then they get admitted to the ICU because the blood pressure is super low. So now they're on vasopressors. This is the fourth hospitalization they've had in the last 6 months. And the patient is super ill. There's nowhere for me to put a line in. He's gasping for air. His lactic acid is super high, which means that the organs aren't getting enough oxygen. And then I'm thinking to myself, why hasn't anyone spoken to this patient about their goals of care? I mean, is this what they want to do? I mean, do they want to live their last days in the hospital? Do they want to live their last days on a machine? It seems like no one has had this conversation. And a lot of times, these kinds of conversations fall to me in the intensive care unit, or as my previous guest, Dr. Colleen Smith, who is an emergency medicine physician, also said, falls to her in the emergency department. And that is the absolute last place that should be the venue for a goals of care conversation. And what's worse is that so many clinicians will say, will turn to the family or maybe even turn to the patient when the patient is scared, can't breathe. All right. When you're facing death, like I did, all right, when I was having chest pain in the ICU and I had to go to the cath lab, I'm terrified. It's very frightening. It's very scary. And I was breathing fine. Imagine if I couldn't breathe, if I felt like I was suffocating. I mean, that's the absolute worst time to ask me, hey, do you want me to do everything? Or same thing, the family, horrified family that's watching their loved one gasp for air or their loved one maybe trying to die in front of them. And then you turn to them and say, do you want me to do everything? I mean, that is the worst context to have that kind of a conversation. And that question, do you want me to do everything, is the worst question to ask. Because when you ask that question, when you say, do you want me to do everything, that connotes that, I'm just happy to watch you die. I don't feel like taking care of you. And that's absolutely that's not the question that's being asked. The question that's being asked is, what is your goal of care? What do you want to be done if you are facing the end of your life? Do you want to die on machines? Do you want to die on being dependent on a tube to breathe, a tube to be fed, where you not be able to talk, where you can't walk, you can't do the things you used to do? Is that the kind of life that you want to live in your last moments? Or do you want to live with comfort and dignity with your family, and spend your last moments on this earth that way? That's the question that's being asked. Do you want me to do everything is just the worst way to frame it. And I can't, it really, it's very bothersome when clinicians ask it that way, right? Or I kind of talk about quote unquote code status. Once again, code status, quote unquote, means that if the heart stops, do you want me to do CPR? Shocking. And CPR breaks ribs. Sometimes it could break the sternum, right? The breastbone. The question that should be asked was, if the heart stops, do you want to die naturally? Or do you want me to pound on your chest and shock your heart, right? An even better way that I found to ask the question is, if mom, dad, your husband, your wife, your brother, your sister saw themselves in the bed, hooked up to machines, what would they say? I have found that the way to frame it that way is so much more effective because, again, it's taking the burden of a life and death decision off of the family and puts it back where it belongs, the patient, right? Before all this happens, again, this kind of a conversation belongs in the primary care physician's office, not in the hospital emergency department, not in the intensive care unit. It belongs in the primary care physician's office. And that's and when we help save primary care by one, adding more primary care physicians, compensating it better, and then, like my guest last week, Dr. Bobby Scott, talked about removing the unimaginable burden off of primary care, and where he suggested um, um, delegating to a physician physician overseen protocol that deals with chronic disease management, stable chronic disease management, so that it loosens the burden off the primary care physician, where the chronic stable disease management is off of their plate, and then they can focus on things like a goal of care conversation, which takes time and it's emotionally fraught, and it's very difficult because people don't like to think of their end of their lives. And it's so important. If you have a condition, even when you're healthy, that's the best time. It's just like writing a will. Your will is best done when you're of sound mind and body, and your goals of care should be done when you're of sound in mind and body, so that what you want done to you at the end of your life is protected and is honored by the healthcare team. And you need a primary physician who knows you the best, knows the ins and outs of your care, knows you as a person, um, can best determine that that goal of care. And it's most comfortable with someone who's very familiar, such as your primary care physician, not a brand new stranger doctor who you've never met and doesn't know you as well, to have that kind of conversation. Now, I love having those conversations. I'm very honored to have those conversations um, because I'm helping to mitigate the suffering of my patient. And at the same time, if I never have to do another goal of care conversation because they're all done in the primary care physician's office and they're properly communicated to me, wonderful, no problem. That would be a wonderful thing and a great service. And the way we can take take goals of care conversations and put them back where they belong in the primary care physician's office, we have to unburden primary care docs and um, and give them the bandwidth and the time to have these difficult conversations, which are absolutely essential to the care of the patient. So um, I'm loving. I love to have them. I'm going to continue to have them. Meaning me conducting goals of care conversations, and we need to help the primary care physician to give him or her more time to do to take care of these sort of things, because really, really, at the end of the day, goals of care conversations belong in the primary care physician's office. Thanks so much, everyone, for your time and attention, and I'll see you next time in Healthcare Musings. Thank you for listening. Sign up at healthcaremusings.com to get every episode delivered directly to your email. And please don't forget to leave a 5-star review. Thank you so much.